Hello, I'm Will. Welcome to ResearchPod. Pain is a tricky thing to diagnose and treat. One person's inconvenience could be debilitating for another. Chronic pain comes with even further complications and affects a great many more than you may expect. Dr. Lauren Harrison is a pediatric pain psychologist and pain researcher at Stanford University School of Medicine. Today we're talking about her recent research and current trial focused on user-centered development of digital-graded exposure intervention for youth with chronic pain, with a specific focus on optimizing the development of digital tools when funds and technical knowledge are low. Dr. Harrison, hello.
Hi, thank you so much for having me. My name is Lauren Harrison. I am a clinical psychologist by training and an instructor at Stanford University School of Medicine, where I hold mostly a research position, but also work clinically in our pediatric pain rehab program.
Could I ask a little bit in terms of the background of how you wound up in that kind of program? What about this field drew you to this kind of research, and how timely is your involvement in it?
So I received my PhD in clinical psychology from Eastern Michigan University, but prior to that did a master's in clinical psychology down in Houston, Texas, where I did a clinical rotation at Shriners Pediatric Burn Hospital. That was my first experience with pain, more of an acute pain setting, obviously, but a lot of the principles that we use when supporting kids working through chronic pain situations were present there as well. So things that we use to support comfort and coping, distraction, and then supporting parents in dealing with the distress of their child's pain. In my PhD training, I did clinical rotations broadly with kids with a variety of chronic medical conditions and in a variety of intensive inpatient, consultation, liaison, and outpatient settings before moving on to my residency training at Kennedy Krieger Institute at Johns Hopkins School of Medicine, where I did primarily inpatient rehabilitation services as the behavioral psychology provider. So working really closely with kids with chronic pain, but also spinal cord injury, brain injury, post-ortho surgeries, and working very collaboratively with the other rehabilitative services. So physical therapy, occupational therapy, speech and language, and just really, really enjoyed the collaborative nature of that work and watching these kids get better. That's one of my favorite things I think about working with children is that they're so resilient. And after my residency training, I came out here to Stanford in 2018 to do a pain-focused fellowship. And I've been here ever since. Oftentimes when I tell people that I work with kids with chronic pain, the response I get is, kids have chronic pain? And it's actually a pretty pervasive problem. So 1 in 4 kids, it's estimated, will experience chronic pain. And the impacts of this chronic pain on their daily lives are really far-reaching. Kids are having difficulties attending school, participating in sports or other social events, engaging with friends and family. In addition to the physical experience of the pain, a lot of these kids are experiencing significant impact to their psychological and social functioning. And if left untreated, the pain can persist. Having chronic pain in childhood and adolescence is a really significant risk factor for having pain as an adult, with societal costs exceeding $19.5 billion in the US each year alone.
That's a big number.
It's a big number. And I think when we think about the various domains that are impacted by chronic pain and the things that are driving them, so oftentimes children will, and adults, present with a pain problem to first their primary care physician, who then, let's say they have ongoing stomach aches, might send them, and again, we're speaking in the United States healthcare system here, so they'll send them to GI, gastrointestinal doctor, who might run a bunch of tests and try a bunch of medications and not be able to figure it out. And then they might send them back to primary care. The patient still has pain. They might send them to internal medicine or another specialty provider. So usually by the time patients make it into our pain management clinic, they've been experiencing pain for many years, and they've been to many, many, many medical providers. And so when we start to conceptualize chronic pain as a biopsychosocial problem and looking at mechanisms like pain-related fear and avoidance as being drivers to impairment, we can then start to intervene on those mechanisms through cognitive, behavioral, and physical and rehabilitative therapies.
I mean, it's no wonder that they come to you with pain and fear and probably a lot of baggage and trauma along the way.
Yes. Yeah. A lot of emotional distress, not just in the children and teens, but in the caregivers as well.
Well, to think about the two different, I suppose, elements of your work when it comes to pain and working with children, how different is the experience of chronic pain and chronic pain management between adults and children? And then how is working with a child as a person, let alone from the experiences they have, but as an individual, different from working with an adult with any other health concern?
In the work that we do with kids with chronic pain, we tend to really focus on function. There's definitely space and effective medications and medical interventions. But usually the primary push for these kids is to get them back to school, get them back engaging with their families and their friends. A lot of the activities that they've stopped doing because there is the pain present, or there's the fear that the activity will exacerbate the pain. So in the context of the work that I do clinically with kids with chronic pain is more focused on supporting them in returning to function, trying to cope with and manage the pain, but really focusing on expanding their day-to-day activities and what they're doing in the context of normal waking hours. And usually what we see is that pain decrease follows functional increase. So that tends to be our primary focus in treating chronic pain in kids.
And when you talk about the nerve signals for pain, where there oughtn't be that, the interventions to treat that, is that to, physically intervene in the neurotransmitter signal, or is that a more psychological approach to manage those signals and, lessen them through whatever psychological conditioning rather than direct physiological intervention?
There are interventions directly onto the nerves to try to cut those signals. And sometimes those are very effective. And in the cases when they aren't, we move more towards a physical rehabilitative approach with the psychological support to try to, let's say, for example, a child is having a significant amount of pain in their foot post, maybe there was a break. The break has healed, the pain remains, the pain might even be worse. So what we're needing to do is get them to walk, even though everything that they're conditioned to do, how they're conditioned to respond to pain would be, I can't walk. So we need to get them engaging in those movements. The physical rehabilitation of walking, however that sort of starts and builds up, and then sort of the behavioral and the psychological support to be able to actually do that, cope with doing that, and then the mindset shift that's required to say, even though my body is telling me I'm in pain and this is dangerous, I know I'm safe and I need to push forward and engage in this exercise and eventually know that the pain comes down.
And what kind of rates of success do you see with that therapy?
For the pain rehabilitation clinic, we're seeing kids 5 days a week, typically 8 to 3. So working in a much more intensive setting with and working interdisciplinarily with physical therapy, occupational therapy, nursing, medicine. So we tend to see kids get better, but it's a different treatment. It's a more intensive treatment. We have kids in our program for up to 12 weeks. So it takes time. And a lot of the kids will discharge from our program and still need some additional supports, but we'll have made pretty significant functional improvements, able to return to school if that was the plan, returning to daily activities, engaging with the family.
How much of a barrier to accessing care and to recovery is the intensity of having to be in the clinic for those, days of the week, to be traveling all of the time, the pressure on the families that puts on them, like wait lists to get there, the monetary demands of it, everything outside of the care that impacts how successful that care is?
They're high. I think the burden on families to come into these programs is high. Parents are taking off work. Sometimes families are relocating temporarily into hospital-based housing services. And it's typically not only one caregiver and one child that makes up the family unit, I think the impact of pain is far reaching beyond the domains that are impacted for the child. So far reaching on the family unit. And I think that in addition to access to care barriers, insurance barriers, it's a high cost, high demanding intervention. With digital health, we have this unprecedented opportunity to increase access to care. And there's certainly been a lot of work and government grant dollars put forth to support the development of digital tools, digital interventions. I think where we still have a lot of room to grow is in assessing how do we increase engagement and usability with these tools. The work that's been done, at least in pediatric chronic pain space, shows that outcomes of the digital tools that exist are pretty similar to outcomes for in-person interventions. So when we think about treating kids with chronic pain, the gold standard of care is cognitive behavioral therapy. So that's an intervention delivered by a psychologist or a psychological provider where we're targeting the child's thoughts and emotions around their pain and their behaviors, how they're either behaving or engaging or not in relation to their pain. And so we're using the broad cognitive behavioral therapy interventions and really tailoring them to chronic pain. And so we see changes, we see improvements, but with cognitive behavioral therapy being a broad intervention that's targeting several different domains, sometimes all at the same time, it's hard to really suss out what mechanistically is driving the change or not driving the change. And so there's been this push to really dive into specific mechanisms of these behavioral interventions to try to see, can we isolate a mechanism or figure out what isn't contributing to improvement or might be taking away from improvement to see if we can enhance these treatment outcomes. Exposure is a longstanding behavioral intervention that is most often used to treat people with really significant anxiety disorders. So the idea is when we have a stimulus that we're afraid of, we tend to avoid it because our body is conditioned to avoid things that we're fearful of. So with exposure therapy, we are supporting people engaging in the things that they're having in fear response to that has caused avoidance that is now non-functional. So the same principles of that are being applied to chronic pain. The work first started in adults with back pain, trying to get these adults to engage in these movements that they weren't engaging to due to the presence of pain or the fear that engaging in that movement would cause pain to increase. So it's targeting not only the physical movements of the exposure, but also the cognitions and the appraisals and how we are interpreting what pain means. When I first came to Stanford as a fellow, my clinical position was on a clinical trial examining a graded exposure intervention in kids with chronic pain. So my primary mentor at the time, Dr. Laura Simons, had adapted the graded exposure treatment that was being done in adults for kids. And that intervention is called Get Living. And we examined that intervention in a 2-arm randomized controlled trial against the current gold standard. So cognitive behavioral therapy for chronic pain and physical therapy for chronic pain. The graded exposure intervention in the context of the clinical trial was delivered jointly by a pain psychologist and a physical therapist. So in both arms, we had both disciplines, but the core components of the intervention are different. So in the exposure intervention, there's focus on the cycle of pain and avoidance, how that incorporates aspects of parents and family functioning. So how a parent's appraisals and behaviors around pain can contribute to a child's appraisals and behaviors around pain, how they're emotionally responding, how they're behaviorally responding to the pain and to each other. We do a lot of values-based goal setting. So rather than setting arbitrary goals that might be important in the day-to-day life of a child, we're asking them really specifically, like, what is important to you? What do you want your life to look like outside of the context in pain? And we try to set goals related to that. And then we look at their physical movements and what they are and aren't able to do and set some activity goals around that. the meat of the intervention is getting them to engage in these activity exposures. So the clinical trial that we ran took about 2.5 years, and a significant portion of that happened in the context of COVID. But what we saw essentially is no differences in the outcomes between the interventions. So the exposure intervention functioned just as well as the current gold standard of care. Patients improved in expected directions regardless of the intervention. We also saw no differences in improvement for those patients who received the treatment in person or virtually due to the pandemic. But that study, and I think the context of the pandemic, really sort of set the stage for us to try to see if we could create a version different from like an hour session on telehealth, which is still burdensome, albeit less so than presenting to the clinic, but to see if there's a way to modify the exposure intervention into a more self-guided, self-paced digital format. And I think diving into that work and being connected with mentors and collaborators who have been doing work in this space for a long time, it sort of sparked all these questions about, we have a lot of effort and energy, time and money that's being put into the development of digital tools, but like about 28% actually make it into healthcare. So there's a significant amount of research waste when it comes to these digital interventions. And in working closely with my collaborators, so my mentor, Dr. Laura Simons, Dr. Ricard Wixell, who's at Karolinska Institute in Stockholm, Sweden, we started talking about how do we be a bit flexible in our methodologies, maybe pull in some other methodologies that have been used in other psychological research spaces for many, many years, and also consider how are these tools being developed in industry. There's a model that we have been basing our most recent work off of. It's the mHealth Agile Development and Lifecycle Model, which really seeks to provide a framework to take what's being done in academia and what's being done in industry and essentially marry them together. So integrating the rapid iterative development process used in industry with empirically driven behavior change theories of academia to engage end users in the development process to produce a digital tool that is meeting their needs and contexts, empirically driven, and can be widely disseminated. In developing the digital version of the graded exposure intervention, we tried to really take that approach. So I would say our top priorities have been to engage end users, so in this case, teens with chronic pain, in all aspects of the development process, to take a really agile and iterative approach to the development process, and to try to do it relatively quickly, which is a challenge in academia, particularly when you're working in digital technology spaces, because we don't tend to have a ton of money to put into these interventions or to partner with people who know how to build really effective and enticing digital tools.
How does a clinician get into software and apps, or how does an app developer get contacted about some medical work rather than, another version of Angry Birds or something?
Yeah, that's a big question and gap in the digital intervention development that's happening in the context of academia. We had this idea to develop a digital version of this intervention, and it's, so to speak, like looking around the room of like, who's done something similar and what have they built their intervention on. We spent a lot of time at the beginning trying to figure out what is the best platform to build this on. The tools that we have available to us are not going to be exciting visually oftentimes. They're pretty basic, but they've been widely used in studying the preliminary efficacy of interventions and the feasibility of people using them. So we initially opted to use a platform that's been widely used to study behavioral interventions in youth and adults. And sort of making that decision, I think what's really important in academia when we think about trying to speed up our process, it's these decision points when it would be very easy to get hung up on, oh, you got to find the perfect platform, or knowing we don't have this much money or we have these limited technological skills, like what do we do? And that is daunting. I could speak from experience, but we kind of got to this place where it's like, we have this established platform available, let's go. Making that decision allowed us to tailor and tweak the content from the in-person intervention, get it into a platform, and get it in front of kids with chronic pain and let them tell us what they think. So we ran 2 cycles of those interviews in the initial platform and got to a place where essentially the kids were like, we understand the purpose of this intervention. The content is clear. We like it. The platform is very boring. They had a lot of ideas for how it should look and the things that it should have. Then again, as a research team, we're back in the uncharted territory of, okay, now what do we do? The primary focus of this project was to have it be developed and designed based on the user feedback. I remember a point in time where we sort of stepped back and we were like, okay, well, we can go forward with what feels certain and known, which would be to continue with this platform. There were a few modifications that could have been made. A lot of the things that we were asking for could have been made, but they would have been very, very, very expensive and taken a long time, like over a year. We needed to move quicker than that. That was also one of our big goals, was to not spend years and years and years and years developing and then years and years and years testing this tool so that by the time it's ready to be integrated into healthcare, it's then totally obsolete. So we had a couple of weeks where we then just started reaching out to freelance software developers and app developers, talked with a couple of colleagues who have partnered with industry, and quickly realized that that was not going to be an option. Again, we don't have a lot of money to develop this tool. And when I say not a lot of money, I mean like $30,000 in total for the project. In talking to freelancers, we started paying attention to the websites and platforms that they were commonly using. So we have no-code, lower-cost platforms that a lot of the freelancers were saying, oh, I would build this on that platform, or I'd build this on this platform. And my research coordinator, Sarah Webster, and I one day were like, why don't we just see how easy it would be to build one of these websites? So we just decided to try and see what would be available to us, again, with very limited money, very, very limited tech knowledge. But could we build something that was good enough, would meet the needs of the teens, the things that they were saying they would need in order to engage with this daily, that would allow us to then be able to test what is the feasibility of an intervention like this? What is the likelihood of engagement? What's getting in the way of non-engagement? And then to test the efficacy of the content. So we're in the last phase of refining that intervention. When we finish this round of interviews, we'll finalize things and then prep for the second part of the trial, which is to examine feasibility and preliminary efficacy of the intervention. And we're planning to launch that on a small sample of participants. So we proposed N of 20. We're incorporating a methodology called single case experimental design, which has long been used in behavioral research and is starting to be integrated into the behavioral health space. But essentially with this methodology, you're looking at changes within the individual at repeated time points over the course of the intervention. And so we're able to see at the individual patient level, when and where are they having changes or improvements, and when are they not? And instead of needing to wait until the trial is complete, with single case experimental design, we're able to examine the data in real time. So we can change and make adjustments to what is being done in the context of our intervention. The next steps for us are really trying to look at implementation and adaptation into healthcare. So our next steps are to engage 3 clinics in our children's healthcare system where patients with chronic pain tend to present. So our pediatric pain management clinic, a sports and orthopedic medicine clinic, and a rheumatology clinic, and really take sort of a service design approach to assessing implementation and adaptation. Essentially, what this means is we'll have a period of time of observing workflow in each of those clinics, conducting interviews and focus groups with various providers in those clinics. So it might be a medical physician, a psychologist, a social worker, a nurse, anybody who's having touch points with patients where they might be delivering or following up on status or recommendation. And then trying to understand how this digital tool would potentially be implemented into their workflow. So trying to assess those pieces, the pieces that I think are really important for adoption and implementation of these tools before then launching a larger multi-site trial. The hope there is that we're answering all of the questions that we would be left with at the end of a multi-site trial had we just moved right into it.
Would you say that app development and mobile health technologies is for everyone, either from, the peer and professional side or from the patient side of what they are getting out of it?
I would definitely say for both researchers and clinicians and patients, there are different strokes for different folks. As a clinical researcher, using the knowledge that I have of how things work in a clinical space provides additional insights for how we develop things from a research perspective, as opposed to being somebody who's isolated in either environment without an understanding of, the logistical barriers. And for patients and for families, there's going to be some kids that are really going to like the idea of a self-guided app and some kids who aren't. The big goal in developing this tool is to try to create something that will meet the needs of the people that will use it and will engage with it and will benefit from it.
If there's any patients or clinicians who think that they might have candidates that could be eligible for enrollment in either this stage or further development, what should people do having heard this, and where can they find out more?
I mean, anyone who's working in this space, in the digital intervention development space, I would be happy to connect with. One of my big goals in this podcast and some of the work that we're about to publish is being very transparent about our process and trying to shift how we approach the development of these digital tools in early stages within academia. So recognizing that there are low cost, no code technical solutions that are accessible and allowing us as researchers in the field of digital intervention development to move forward beyond those barriers, I think, where the field used to get a bit stuck. So being a bit flexible and creative, my hope is to share our process and to collaborate with others who are interested in or pursuing similar work. If there are teens with chronic pain who are wanting to get involved, we're always looking for people with lived experiences to act as advisors and consultants and partners in our research. So anyone who's interested in reaching out, you can find me on Twitter or via email as well.
Thank you so much for your time today, and fingers crossed we get to hear more from you soon again.
Thank you so much, Will.